I want to talk about maintenance fluids because I have a little bit of a reputation at our hospital to get very stressed out about the terminology and the concept of maintenance fluids. And I hope that in 20 minutes you'll understand why. So my objectives are to discuss maintenance fluid management from a nephrological perspective especially, and to provide some recent updates because other people have been thinking about and working on this concept as well. And then briefly go over some of the basic and salient features of commonly used intravenous fluids. First of all, the best intravenous and the cheapest intravenous fluid is no intravenous fluid. So if you can treat your patients who may be dehydrated or whatever the reason is for their fluid needs, if you can treat them enterally, you're going to make everybody's life easier and cheaper and perhaps even a little bit safer. But there, of course, are patients who don't meet those criteria and will have to be offered intravenous fluids. So here's a recent case. I was on our inpatient service a few weeks ago, and one of our long-term kidney transplant patients who was doing very well with his kidney transplant was being seen with a history of several weeks of diarrhea and more recently also vomiting. And in addition to that, his parents had given him some ibuprofen to help him feel better, which hadn't been working so well. So he was evaluated. He had lost a few kilos of weight since his last office visit with us. He was overall not too dehydrated looking on exam. His pulse was 103. He was afebrile, but his blood work showed that his serum creatinine had increased some from his baseline of 0.7-ish milligrams per deciliter to just over 1. And we have these rapid stool pathogen tests now where you can, if you get a stool sample within an hour or two, you can find stuff to make a diagnosis, and his stool happened to be positive for norovirus. And so that took all day, so he was admitted in the evening for IV fluid management because he was weighed down. We didn't know if he could tolerate enteral fluids because of his recent onset vomiting. And when I rounded with the residents in the morning, the junior resident, the intern, told me that he had been placed on, quote, maintenance fluids, unquote, for rehydration. And that understandably, and I'll show you why, resulted in some extra teaching about this concept and about the thought behind maintenance. The thought behind maintenance, what is the real meaning of maintenance? The concept of maintenance was developed in healthy children who are at steady state, who are out at home doing well, who don't have fevers, who aren't vomiting, who don't have diarrhea, and who aren't sick in the sense that being sick dysregulates their ADH system as well. As you know, not only GI illness, but a whole another slew of health derangements, pulmonary issues, pain, all of the stress, all of the surgical stress, all of that can dysregulate ADH, usually upregulated, and affect fluid status and water balance under any of those circumstances. And maintenance in a healthy child who's doing well, who's at steady state, indeed, is insensible losses, and we'll talk about that. There's numbers for that, and whatever comes out of that child as measurable output. And the same holds true for sodium. There's no reason to think, on sodium and water, that there's some sort of acute dysregulation. Now, as far as hospitalized children is concerned, however, hardly any of those children in the hospital will meet those criteria, because if everything was well and steady state, they probably wouldn't need to be in the hospital. So the only even remote examples I can think of to whom this kind of concept would apply are perfectly healthy children who for some reason are admitted for some procedure and for some reason need some IV fluids to get them through that procedure. I picked some ENT surgeries here. In them, you can probably, without thinking too much extra, apply this maintenance concept, because overall they should be pretty much in steady state. And what does that mean? Well, you can all look up these formulas, Holliday-Seeger, or the 4-to-1 rule, or the BSA method, so you can calculate how much maintenance fluids a child is expected to need per hour or per day based on their body weight or their body surface area. So that's where these formulas are coming from. Now, what does maintenance not mean? It, like I said, means very little in somebody who is sick, who's in the hospital, who has dysregulated ADH. It means very little in somebody where the insensible losses are altered, either because of fever, that it obviously increases your insensible losses, and or in somebody who has altered measurable output, whether that's vomiting or diarrhea, increasing the output, or in my world, oliguric renal failure, renal kidney injury, where output is decreased. And it certainly also doesn't mean much as far as sodium and water balance is concerned. If somebody, for example, has increased GI losses of sodium because they're having some sort of gastrointestinal illness, in somebody who may have increased skin losses, I'm thinking about extreme examples like premature babies or burn victims, burn patients. And then, of course, there are all kinds, again, in my world, all kinds of renal tubular losses that can happen as well. And so, unfortunately, that probably, or at least some of this, applies to just about any child that's hospitalized, because otherwise they wouldn't need to be hospitalized if they wouldn't be sick in any specific way. And so, normally we think, as I mentioned, of sensible losses, which is basically urine and stool in somebody who's healthy and not vomiting, and those usually contribute about 2/3 to maintenance fluid needs. And then there are the insensible losses that we accrue by breathing and by sweating, and that's the other, typically in somebody who's doing well, who's healthy, typically 1/3 of what we call maintenance fluid needs. Of course, as I said, those insensible losses can be increased in fever, in tachypnic conditions, but they can also be decreased, for example, in intubated patients who are being ventilated with humidified air. And so in our patients who are in the hospital, we have to supplement and adjust our maintenance concept, usually with either with some kind of deficit repletion or with adjustments for decreased losses. If somebody has gone into oliguric acute kidney dysfunction, then if you put that person on maintenance fluids, you're going to fluid overload that person, because that person no longer pees as much as he or she would need to be peeing to fit into the old-fashioned traditional maintenance concept. And so how do you estimate how much off of your old-fashioned or your healthy maintenance range those patients are? Well, you can do a physical exam and look for signs of dehydration, such as tachycardia, skin turgor changes and things. Obviously, if you have weights to compare, which you don't always, if somebody is ending up in the hospital off the street and there is no weight from a week or 2 or 3 or 4 ago, weight changes will help as well. And obviously, there are also signs of fluid overload, such as edema and hypertension and stuff that you can look for. Even if you do a perfect job, however, assessing where this particular patient stands when you start treating him or her in the hospital with whatever maintenance plus deficit repletion or whatever adjustment you're going to prescribe, nobody knows how much more febrile is this patient going to be in the next 24 hours? Where is that patient's vomiting and diarrhea going? Is it going to get better? Is it going to get worse? Again, back to renal dysfunction, will this renal dysfunction get worse from oliguria to anuria, or are these kidneys going to open up and start making more urine? And as you know, in acute kidney injury and resolving ATN, for example, there can even be a polyuric recovery phase. So you don't know what your patient is going to do in the next 24 or 48 hours, so you have to keep watching that patient and monitoring that patient, and you're going to have to make adjustments in your fluid strategy based on what the patient does going forward. And so it's really important in the hospital to monitor ins and outs in some way, to get regular, probably typically daily weights, and to look at the patient once or twice a day and see, does he or she look like, based on physical exam vital signs, like we're moving in a good direction fluid-wise, or are we not helping this child? And then we'll talk a little bit about sodium, especially. Of course, blood work is helpful to monitor matters as well, kidney function, but again, more importantly, in general terms, sodium, because there can be all kinds of derangements as far as sodium in those fluids is concerned as well. And so, as I said, this was just published in November of last year. Others have thought about this too. This is a study from, I forgot where, but it's some big children's hospital on the east coast of the US. And they got so stressed out, understandably and appropriately, about doing the right thing as far as IV fluids for children in the hospital is concerned, that they developed a clinical pathway because improper use of maintenance IV fluids may cause serious hospital-acquired harm, and that therefore they created an evidence-based clinical pathway to guide providers in the indications for fluids, its preferred composition, and appropriate clinical monitoring. Obviously, one of the most dreaded complications of unsuccessful IV fluid management, especially in children, is hyponatremia, because that can, worst case scenario, lead to seizures. But if you monitor these children and you find that they have developed significant hyponatremia, you also have to be careful correcting that, because if you correct it too aggressively, then you can set this child up for central pontine myelinolysis. So what did these people do? I don't want to read all this to you again. Clinical pathway. I would point your attention to the last part of the methods section. They specifically followed median duration of IV fluids, proportions of isotonic and hypotonic IV fluids, adherence to monitoring recommendations, and incidence of associated severe hyponatremia. They also looked at potassium use and costs. What were these monitoring recommendations that I put a red asterisk next to? Well, they were daily weight and recommended serum sodium testing. I couldn't see in the article, maybe it was in the supplement somewhere or something, what exactly those recommendations were, but they did daily weights and they got repeated blood work looking for, I guess, renal function panel that has electrolytes in it and stuff. Depends a little bit from hospital to hospital. And their recommendation, their pathway, was to prefer isotonic IV fluids, and that's based on several studies like this one that have shown that isotonic fluids are safer than hypotonic fluids in hospitalized children requiring maintenance IV fluids in terms of serum sodium concentrations, meaning the risk for hyponatremia. So that's one of those articles. There's another one that I quoted here because Dennis Geary is a famous pediatric nephrologist, so that caught my attention. Same conclusion, isotonic maintenance fluid administration is safe in general pediatric patients and may result in fewer cases of hyponatremia. Now, so what exactly are we talking about as far as fluids here is concerned? Well, the two quote-unquote isotonic fluids that we usually think of are normal saline and lactated ringers. And then everything else, half normal saline or D5 half normal saline, is obviously somewhat hypotonic, and I don't know that we need to talk about quarter normal anything, because most of the time those are actually probably too hypotonic. And then the flip side of that obviously is that normal saline has 0% free water and half normal saline has 50% free water, which is the other half is sodium chloride, which is why it's called half normal saline. Now, I have some thoughts about this, and to show you why, I want to do some math with you. So let's say a child that weighs 15 kilos needs to be in the hospital for some reason and needs to be placed on maintenance IV fluids. And so based on that 4-to-1 rule, an hourly maintenance fluid rate for a 15-kilo child would be 4 mLs per kilo per hour for the first 10 kilos of body weight, and then 2 mLs per kilo per hour for those 5 other kilos of body weight, which is 40 plus 10 is 50 mLs per hour, or over 24 hours, that would be 1,200 mLs a day. And so if you give this 15-kilo child those 1,200 mLs of maintenance fluid volume in 24 hours, if you give that as normal saline, as isotonic normal saline, which I just showed you contains 154 milliequivalents per liter of sodium, then that is 1.2 times 154, 184.8 milliequivalents of sodium per day, or over 12 milliequivalents of sodium per kilo per day for this child. You're shaking your head. Is the math wrong, or you think that's too much? What's that? Yeah, I don't like it either. That's why I did the math here. So for those of you who don't know what the daily normal sodium needs in a healthy child are, they're between 2 and 4 milliequivalents per kilo, so 30 to 60 milliequivalents for this child who is about to get 184. And so no wonder in these studies that used isotonic maintenance fluids, the risk for hyponatremia was very low, because they get so much sodium that it's not impossible, but very unlikely that they're going to somehow become hyponatremic, maybe because their ADH dysregulation trumps this excessive looking amount of sodium supplementation. And so we've looked at hyponatremia and seizure risk in some of our kidney transplant patients, so it's not that we don't worry about hyponatremia, but excessive sodium supplementation in IV fluids is not without risk either, especially if kidney function is abnormal, because all that sodium can make it very hard, especially for struggling kidneys, to get rid of the fluid that comes with the sodium and sets up these kids for fluid retention. And so you can get into trouble, or those kids can get into trouble with edema, including pulmonary edema and hypertension, and we sometimes get called about that. And one of the first things we very often say is, how much sodium is this kid getting every day? And you might want to reduce how much sodium you're giving this child. So here's my other case presentation. I had to go to a morbidity and mortality conference not too long ago because, again, this is a real case. I don't know if that child was really 12 years old. I just put it in there. It wasn't a very small person who had very mild chronic kidney disease related to obstructive uropathy, but was voiding normally and stuff. And he was admitted to our hospitalist inpatient service for pyelonephritis and dehydration. And because of this intercurrent illness and his probably underlying mild chronic kidney disease that comes with decreased renal reserve, he did develop some acute renal dysfunction during that hospital, at the time of this hospitalization, with a peak serum creatinine in the 2s, whereas his baseline was in the normal range, less than 1 when he was doing well. So his calculated fluid regimen to correct his deficit, his dehydrated deficit, and to provide maintenance was administered all with normal saline, so isotonic fluid. And a few days into the hospital stay, his weight had indeed increased back to what was thought to be his baseline, 2 or 3 kilos up, not very much further beyond what he apparently weighed in the past or was his baseline weight. And his acute kidney injury was beginning to improve, and of course there was no hyponatremia because he got all this normal saline, but he did develop respiratory distress and had pulmonary edema on chest x-ray, which puzzled our hospitalists, but they were able to get this child out of his trouble just with some furosemide and fluid adjustments, and the child did well. So in summary, I feel pretty strongly that the traditional quote-unquote maintenance fluid concept, because it is derived from healthy children in their steady state, needs to be used with caution and in an individualized way in hospitalized children. And when an inpatient receives IV fluids, regular monitoring of this patient's clinical fluid status by tracking ins and outs, weights, etc., like I just mentioned, needs to be strongly considered, because you just don't know how much worse or how much better this patient is going to get over his or her next hospital day or the next hospital day. And while isotonic IV fluids do reduce the risk of hyponatremia, they do supply very generous amounts of sodium, which can also cause problems, especially in the context of renal dysfunction, where these aspects can be very dynamic and challenging and require meticulous monitoring and attention. Thank you.